In this episode, you'll meet an expert who will help us understand cardiac risk for rowers.
Feel the grip of the oar handle, smooth yet firm in your hands. Taste the salt of your own sweat and the occasional splash of water. It's all part of the journey. Welcome to another episode of Faster Masters Rowing Radio. Each week, our host, Masters rowing coach Rebecca Caro, dives deep into the world of Masters rowing. Whether you're on the water or in the gym, join us to become a faster master. Let's go rowing.
Hello, everybody, and welcome back. Today, I'm excited to have a guest with me for this podcast. Becky Wilson is a returned rower whose professional work as a physical therapist with a special interest in cardiac and neuro rehabilitation means she understands how to age well with chronic conditions. Welcome to all her friends at Falcon Rowing Club in Oxford, and Becky also. Welcome to the show.
Hi there. Hi, everyone.
So we connected online, and I have never actually had a detailed conversation with someone who really understands cardiac risk. What on earth led you into this field?
So, well, the story goes way back, actually. It goes back probably about 20 odd years now. And I had a very dear friend who was a sprinter actually in the GB squad, and he died of sudden cardiac death when I was doing my master's at Oxford University. And it led me into a lot of interest in how these things happen. He was a very healthy man, or seemingly so. But unfortunately, he had a condition which led him to having a very dangerous arrhythmia. And he died very suddenly in his 30s. So at the time, I was involved in medical referral exercise, and it led me down this path of moving into cardiac health as well as neuro eventually as well.
That is amazing. So today, you're going to show us a little bit about the Masters athlete. Take it away.
Yeah. Okay. So the Masters athlete has pretty specific concerns with regards to heart health. So if you remember in your 20s, if you've all been rowing since your 20s, perhaps your 30s, exercising hard, training hard, and then kind of bouncing back and going the next day and doing it again and again and again and again. As we age, our heart ages as well. So we don't have quite the kind of the bounce back that we would have done in our 20s and 30s. And that also goes for our heart as well. So there are changes to our heart that are important. So when we're considering cardiac health, and rowing and doing endurance sport, there are things to consider. And family history is certainly one of them. So knowing your family history, that's risk of heart attacks. So that's myocardial infarction or MI, atrial fibrillation or AFib, AF in the US, stroke, sudden cardiac death, which I just mentioned, and other arrhythmias as well. Hyperlipidemia, that's high cholesterol. So understanding your family history is very, very important. Finding out if there is a risk amongst your parents or if you've had a sibling with any of these, and because it might be relevant to you. And other non-modifiable risk factors, of course, are age and gender. So men are much more likely to have cardiac issues than women, but not obviously women still have the risk with our age as well as we age. So those are the important things to consider. The modifiable risk factors are the things that we can do something about. So these are lifestyle choices, and not that there will be many smokers, I think, in our cohort of people in the rowing community, but nonetheless, smoking should be considered. Diet, so how well we are eating. If we're eating a healthy diet, obviously food that is as close to how you would find it in nature as possible. So less of the UPF or ultra processed foods will certainly reduce cardiac risk. Alcohol intake, so that's really important as well, and these have more effect as we get older. The amount of alcohol that we're drinking has much more of a risk for our heart than it does when we're younger. And there is no safe amount of alcohol as well that we understand that is okay to drink with regards to cardiac risk. And also stress management. So stress management is really important, and it's not something that's spoken about very much, but Obviously, when we're under a lot of high stress, that increases our cortisol in the body, which has its effect on the heart in time as well. And chronic long-term stress does have some impact on cardiac health.
Just got one
Just moving
question.
on. Yeah, go for it.
Is cardiothrombosis part of your family history risk factors?
Yeah. So if that has been something that has come up in your family, I don't know if the caller or the writer is, if this is a near family member that has had cardiothrombosis, or if it is the person themselves, if they've had cardiothrombosis. Is this the person themselves, do you know,
Yeah,
or
they
does it
haven't said,
specify?
so maybe we'll come back to that.
Yeah, so it's just important to get that checked out. If it is a family member, it is something that's part of your family history, then absolutely make sure that that is something that is mentioned by a doctor. If you are coming back to rowing after a break, or you are taking it up as a new sport, or you just need to have a yearly checkup, definitely mention something like cardiothrombosis for sure. Yeah. Okay, so just moving on to the next slide. Yeah, so that brings us on to whether or not we're new to rowing or returning after a sizable break. Maybe you've had children, maybe you've been busy and you've just checked out of the sport for a while and you're coming back, or it's completely new. Definitely get checked out by a physician first. So you will be having to share very detailed family history, and that's important. So even if the doctor doesn't ask you, give that detailed family history of anything medical that's significant. So be that stroke or anything heart related, and your own personal history if it's significant. So if there's anything that's happened to you, anything at all, mention that to a doctor. So if you are new to rowing or coming back after a break, the standard tests that everybody will want to get done are your blood pressure. Okay, so normal blood pressure is considered 120 over 80, so 120 being the systolic and 80 being the diastolic. Although we'd like that to be slightly under, a little bit under is definitely very healthy. And your cholesterol is very important as well. So your cholesterol will be looking for low density lipids and high density lipids. So and knowing the ratio, because frequently what happens with cholesterol is people will get a number and they'll say, oh yes, my cholesterol is fine. But actually more important is the ratio between your high density and your low density lipids, and low density lipids being the more damaging to our arteries that cause atherosclerosis, or the kind of the furring of the arteries that you may have heard of. Okay, so understanding those numbers, your blood pressure and your cholesterol, and being able to watch how those change and understanding what those numbers mean is very important. If you can, an ECG, so an electrocardiogram, is very useful, because then we can detect what the rhythm of the heart is doing and whether or not there are any arrhythmias there. So arrhythmias are abnormal rhythms to the heart. Now, there are lots of different kinds of arrhythmias, and many of them are benign. So you can have things like inverted T waves, and then you can have something a little bit more serious like atrial fibrillation. But nonetheless, an ECG, particularly a 24-hour Holter ECG, where you have an ECG connected to you, and then you go about your day for 24 hours, and there's a little device that records constantly what your heart rhythm is doing. That's much more useful, because that can tell us over a long period of time what your heart is doing, where an ECG in a doctor's office will just give a snapshot of what's happening in that moment. So if you have, say, medical insurance and you're able to arrange for these more thorough tests, and you're coming back to a sport as intense as ours after a break, or if you're new, I would definitely recommend getting these done. An echocardiogram is an ultrasound. So it's a little bit like what pregnant women would get, with a little bit of jelly and then a device that goes over top to see inside. And so that's looking at the patency and looking at the structure of the heart and looking at the valves to make sure that they're opening and closing well, and that there are no leakages or there's no issues with how the heart is moving when it's beating. So that's also a good test to get done. And if you're going to be very thorough, and you are able to do these, then a cardiac MRI, where they use contrast dye, you're in an MRI machine, and the contrast MRI will show if there is any issues with your arteries, so if there's any furring or there's any issues with how the heart looks from a kind of the vessels and the patency of the vessels. A Bruce protocol is a stress ECG. So you'll be hooked up to an ECG while you are exercising, and you'll be taken up to a certain percentage of heart rate to see how your heart responds to the stress of exercise, to make sure that there are no arrhythmias coming up as you're exercising. So that's a very good test to get done. So really, just to recap, the tests that you'll get done in a standard doctor's office will be blood pressure and cholesterol, and the rest are they would be gold standard if you're able to get those done.
A question here. Any advice regarding calcium arterial scores?
Okay, so this one's outside my remit because this is really a question for a cardiologist. But what I would do is speak to a sports cardiologist, because they will be able to tell you about the scoring for calcium arterial scores. So I typically don't deal with that in my work. I deal with the aftermath. So if someone's had a heart attack or has had a heart transplant or angina, that's what I tend to see. I exercise people who have gone through those, but I don't tend to deal with calcium scores, unfortunately. So sorry not be able to answer your question. Okay, so let's move on just to the next slide now. So training adaptations as we age. So pretty obviously, the max heart rate does decline as we age, and we think that's by about 6 to 10 beats per decade after the age of 20. And the reason for this is that the beta receptors in the heart that mediate our response to adrenaline are a lot less sensitive over time. So we just don't have that response that we did as we were younger. So it's quite normal to see that max heart rate go down. And of course, our relative risk of a cardiac event increases. So it's important to monitor our exertion levels with a heart rate monitor, a really good quality one, please, and not just something that's on your wrist, but something that actually sends a message from a chest band to a watch. Much better, okay? And definitely not a Whoop band, but something really good. So a good quality heart rate monitor to ensure that you're working at the correct intensity for yourself, okay? And then coming on to now talking about what correct heart rate zones are for you. And it's very important to know that this is kind of for you and not just for someone of your age, but that you work out the heart rate zones for you. And then we do this through a method called the Karvonen formula, which I'll speak about in just a minute. And it's important also just to check that those heart rate zones are correct as your fitness fluctuates. And let's face it, some of us in the masters community do take time off because we have children or we have something big going on in life or work. So the fitness can fluctuate, we get older. And so those heart rate zones should kind of change as we go through life. Okay. So maybe as a general guess, I'd say maybe update them every 6 months or so. Okay. All right, so this leads us on to the Karvonen formula, which is the gold standard in working out your heart rate zones. Now, this is the one that the BACPR in the UK, so that's a British Association for Cardiac Prevention and Rehabilitation, use with our patients. So you'll need to know a few things. You'll need to know what your resting heart rate is. So if you're not sure how to really define what your resting heart rate is, take it like a week or 10 days where you haven't got anything really big going on. And then every morning before you get out of bed, just have a look at your watch, take your pulse, and then write down your morning resting heart rate before you've been influenced by movement, food, caffeine, stress, etc. Just do it first thing in the morning. Do that over about a week to 10 days. Definitely, if you've been drinking alcohol, that's going to change how your resting heart rate is next morning. So if you can try and do that away from drinking alcohol or having a night of alcohol or anything like that, that would be more accurate for you. And you'll need to know what your maximum heart rate is as well. Now, maximum heart rate has been traditionally calculated using the 220 minus your age. And I'm sure you're all familiar with that, but this is really considered to be inaccurate now, especially for older adults. So I'm recommending everybody try the Hunt formula to calculate your maximum heart rate. So that's 211, and you take away 0.64 times your age from 211. Okay, so that will give you your maximum heart rate.
Very interesting.
So Karvonen, yeah. So you could try that. I'm going to give you an example with using myself in a moment. So grab your calculators. Yeah, so Karvonen calculates zones based on your heart rate reserve. So heart rate reserve is the range between your maximum and your resting. So normally where 220 minus your age would be coming from 0, and let's face it, nobody's heartbeat goes down there. So a better and more accurate way is to use the heart rate reserve method, where we're going between maximum and resting. Here's another question.
Would your resting heart rate be the same as your lowest heart rate when you're sleeping?
Possibly, but not definitely. It really does depend. So I wear an Oura ring, and at night I can see how low my heart rate gets. And ideally, we want that heart rate to drop right down, preferably in the first half of the night. And I can see sometimes mine drops to about 40, and then I wake up in the morning and it's kind of like 43, 44. So not necessarily, but a wearable might be able to give you some information as to how your heart rate fluctuates during the night. And there are some very good wearables now. Are we differentiating? Yeah, sorry, go ahead.
MR and a training MR. What's MR?
Yeah, I would like to know that. Maximum rate?
Do you mean heart rate rather than HR? So perhaps you can clarify that.
Yeah, so the question was differentiating between heart rate and training heart rate, was the question? Yeah.
No, she said MR is max.
So could you just go back to the first difference between a max rate and a training max rate? No, not really, because your training will be done in percentages. Okay, so obviously, if you're doing anaerobic work, you're going to be up at around 100% of your max rate. But if you're doing percentages, you're going to be taking percentages of your max rate. If that answers your question, I hope that does. Do come back if it hasn't. Okay, so let's move on. Karvonen formula, here it is. So we're taking away your resting heart rate away from your maximum heart rate to get your heart rate reserve. So I've used the example of myself. My maximum heart rate is 180 based on the Hunt formula, and I can guess what my age is from that. And then taking away 43, which is my resting heart rate currently, to give me a heart rate reserve of 137. Okay, so that's my heart rate reserve. So I'm going to take that heart rate reserve and multiply it by the intensity that I'm looking for. So we write that down as a point something. So 0.6 to make 60%, or 0.7 to make 70%, or 0.8, etc. Okay, so multiplying that by the intensity to give me my heart rate training range percentage. Okay, and then from that training percentage, I'm adding on my resting heart rate, and that will give me my target training range. So for example, I take my heart rate reserve, which is 137, and I multiply that by 0.6. I get 82.2. I add back on my resting heart rate, and that gives me, for 60% of my maximum heart rate, where let's say I'm targeting 60% for a UT2, I'd be looking at 125 beats per minute. Okay. So if I want to get 80%, obviously 137 heart rate reserve times 0.8, that's going to give me 109. Add back on my resting heart rate, that's going to give me 152.6. So I'm looking at 153 beats per minute for 80% of my maximum heart rate if I'm looking at targeting that range. So my training range, if I'm using 60 to 80%, is 125 to 153. Now that's my personal calculation for myself. You guys can do the calculation. And on the next slide, I do have it recapped for you to write down. And I'm going to hold that page there if anybody interested to write that down. I'm sure this will all be available afterwards. So the Hunt formula gives me 166 max, but I actually go up to 180 when sprinting. Is that good or bad? Okay, well, not knowing your medical history. So there is going to be, and this is Mary, so she's female. So females can sometimes run a little bit higher as well than men do, certainly with cardiac output. But I don't think it's good or bad. I think you also, and I'm going to bring this up later on in our podcast today, is how important it is to go on feel as well as just the numbers. So the numbers are one thing, but the feel is very much another, and that's really important. So yes, I go up incredibly high. I'm what's known as a high ticker. I've actually been through the whole gamut of cardiology tests. I've been in an MRI. I've been on a Bruce protocol. I've had ectopic beats, and I've had athlete's heart. And I've been told I just have a really high ticker. So some people just have a really high ticker. They're very, very sensitive baroreceptors in the heart that just makes you tick a little higher. How do you feel when you're up at 180? Does it feel good? Do you feel exhilarated? Do you feel great? Or do you feel like it's really, really tough and you're not doing so good with it and you're finding it really hard to recover from? So all of those things are very important.
Yeah, I rode with a girl who was perhaps the opposite. She called herself a low ticker. And this was when we were in our 30s, late 30s. She said, if I go over 140, she said, I'm about to die. She was the
Yeah.
opposite.
Fantastic.
Another
All right,
question.
so that's the
Joanne.
so that's the Karvonian formula recap. So same for me. My max rate is 163, and I'm often at 172 for racing. How long of a race is that number safe? Okay, well, you're not doing it presumably for hours. You're not doing one of these really long races that takes you down like the Ouse or something in the UK. And you're sitting at kind of 32 strokes per minute, kind of going at it for, an hour. I think for racing, it's quite common to go really, really high with your heart rate. And it's not that it's unsafe at all. It's also how we train. So I'm going to come on to how important intensity is in training in a moment. But I think for racing and that your number goes really high, I've caught myself really a lot higher as well over my max. So yeah, 5K. Okay. Yeah. So yeah, I mean, it's common to go over your max, particularly if you're well trained. Okay, so as you are deconditioned, it is much higher to hit your max than it is when you are really quite well conditioned. Same for me. My max rate is 163. I'm often at 172 for racing. How long of a race is that number safe? Yeah,
So
well, it really is.
Lady.
Yeah. Yeah. Okay. Same question.
And Mary, from the earlier question about the hunt formula, says she said, "How does she feel? Good, but very tough. My rate goes down within a minute."
Okay. Well, it sounds like you recover well. So, that's also something that we can all look at. I haven't mentioned in my list today, but as you are coming off a piece of training, it doesn't matter if it's a UT2, if it's a UT1, if it's an aerobic threshold or an anaerobic piece of work, just keep your heart rate monitor on and just see how the recovery goes. See how long it takes you to get back down again, because that's pretty indicative of how conditioned we are.
So this is from Denise.
We'll be going over. Yeah, we are going to go over beta-blocked athletes for sure. So that's really important. That's the one drug in the cardiology world that does make a really big difference to how we calculate heart rate zones. And I'm going to come on to that now. So beta blockers and heart rate training zones. So beta blockers, in case any of you are unfamiliar with them, are used to act to control arrhythmias by slowing down the heart rate. Beta blocked athletes will have a reduced resting heart rate and max heart rate as a result of the drug. So using the Karvonian formula as we have it now to work out the zones for beta-blocked athletes will yield inaccurate target heart rates without reducing the maximum heart rate by 20 to 30 beats. So that's really important. So you can play around between 20 and 30 if you're a beta-blocked athlete to try this formula. So for example, if I take a 65-year-old on beta blockers with a resting heart rate of 60, we'd need to use the formula 211 minus 0.64 times 65 for the 65-year-old to get 169. 169 minus 30 for the beta blocker gives us a maximum heart rate of 139. Okay, so that's how we incorporate a beta blocker into the calculation to make sure we're getting an accurate calculation for someone who is on these drugs. Okay. All right, so let's move on to adjustments to training. So we need to utilize our heart rate zones as a guideline, but I will say this, always go on how it feels. So in our industry, we call that relative perceived effort, or RPE. So if you are deconditioned, and that's a polite way to say unfit, if you're deconditioned or you're returning to rowing after a break or new to the sport, definitely try and go on how you are feeling. And I'd go so far as to say, if you're doing something like UT2 work, to tip the ergo screen away from you so that you're not looking at your split. And I will talk a little bit about UT2 and how that is one area that we tend to get wrong as rowers, and certainly in the masters athlete community, I believe that this is the case as well. So UT2, and I'm going to speak a bit about this, should be at conversational effort. So that's between 55 and 70% of your maximum heart rate approximately. This is the concrete foundation to your house. It builds a strong aerobic base and your endurance. It capillarizes the heart muscle and your bodily muscles. It is very, very important to get this right. Okay, so we don't want to start tipping into lactate when we're doing UT2 work. Okay, if it feels like it's hard work, if it feels like it's just like you're really enjoying it, but it's feeling a little harder, you're having to open your mouth to breathe a little bit, take a look at your heart rate, you're possibly overworking the UT2s. So the UT2s, let's face it, they should be quite boring. This is a good time to put a podcast on or listen to an audiobook or listen to some music and just float away for an hour on your UT2s, and you should not be working hard at all. Okay, because this is the work that really builds the foundation for endurance. When you're going to a regatta where there is race after race all day long and you've got to sustain that endurance effort, this is going to get you there. So this is the stuff that really is important. I can't overstate that. That's really important. So a lot of us overwork the UT2. If you're in an erg room with a lot of other people, you all got your erg screens up, you've all got your little screens with your splits on, and you're looking at the person next to you and you're thinking, oh gosh, they've got a low split for a UT2. I better just, and of course we don't want to be seen to be pulling a really slow one. So we start going a little harder. Tip your screen away, and be happy to go slow, because this is the stuff that's really important. If you recover well from a UT2, it means that you've got the energy then to do your UT1s and your ATs and your AN work. So don't overwork the UT2s. Is everybody clear as mud on that one? Okay, UT1s, comfortably hard, sustainable pace. So this is what I would call, comfortably hard. It sounds like a weird thing to say, but it is. Okay, so if you're a runner as well, you'll know this is a tempo run. So it's something that you feel that you're you have to open your mouth at this point to breathe. And it's 70 to 80% of your maximum heart rate, approximately. This is improving the capillarization of the heart. And also, we're now moving into lactate clearance and tolerance here, where we're not doing that with the UT2, okay? Anaerobic threshold work is a hard effort, but still sustainable. We can carry on with it. We're getting up into the 85% of our maximum heart rate, and this is really improving our anaerobic capacity at this point. Anaerobic work or flat out sprinting, very hard maximal effort. And this is like, you won't be able to say a word to anybody. Maximum heart rate here. Okay, improving your anaerobic capacity. All right. Okay, so that kind of covers the adjustments to training. But again, just to recap, UT2s, really important to take them really gently. And I think a lot of us overcook the UT2, and this is what puts us potentially later on at risk of cardiac problems. Okay, so it is the long threshold work that presents the cardiac risk in the older athlete, and I'm going to come on to that. Okay, so let's move on. Training and competing after a cardiac event, is it safe? Yes, it is, provided you've run the gamut with the doctors, you've gone through and been deemed safe by a physician, and had an uncomplicated recovery. Okay, so while you're recovering from something like an MI, a myocardial infarction, there are no complications that come with that. There's no additional chest pain, or you've not been then diagnosed with angina or anything else for that matter. Your condition is well managed and stable through medication. So training, it's really important that if you are newly on heart medication, that you give it some time. You give it at least a month before you start rolling into training, because the body needs that time to settle down into medication. There are, just going to go off piece slightly here, there are some side effects with some cardiac meds, and particularly ACE inhibitors can cause a bit of a nasty dry cough. So if you're on an ACE inhibitor, look out for that as a side effect that can impact training, that can impact how you feel when you're doing your training. Statins can cause some muscle aches and pains. And with those sorts of things, just sometimes switching brand or switching manufacturer can resolve that. Get involved with a cardiac rehabilitation group locally to you, because this will help you with the confidence of returning back to exercise if you are coming back after a cardiac event. And the social support is absolutely invaluable. So I have spent some time working in cardiac rehab groups, and just the camaraderie of people coming together after something as quite earth-shaking as having, say, a heart attack or having a scare with your heart in some way is really useful, just to know that you can come back and go back to exercise. There are people doing it there with you. And really importantly, be on the lookout for changes in how you are feeling. So if you're in doubt, please err on the side of caution and check in with a doctor. If you feel weird one day and it's just like you're extra tired in particular, or you just feel like you're just off, then just don't train, particularly after a cardiac event. It's better to be safe than sorry.
I have a question here.
Yeah, dive in.
It comes in two parts. Daniel says, I'm 45. Last year, I suffered 2 major heart attacks, lung failure, brain damage because of lack of oxygen. I was in a coma. It took me to 3 months to learn to walk again, and I want to play baseball with my grandkids. He goes on to say, I'm trying to exercise, but it hurts. I get tired. I tried playing baseball, but I get so exhausted. Will there ever be a chance of me playing with my grandkids?
Oh, yeah. Yeah. Well, I'm just, I'm sorry for what you've gone through. That sounds really hard. And I can hear the desperation in your message, and I can certainly hear the sadness around that. So, not knowing where you're messaging from, but I would encourage you to find out locally what cardiac rehabilitation groups that there are. If you can find out maybe through your GP practice or your doctor's practice, because they often have a lot of connections to local rehabilitation groups. I don't know if you have gone through this process after your cardiac event already. You didn't say here, but it's important to do that, to get in touch with a cardiac rehabilitation group. Because it'll certainly give you a really measured way to come back to exercise. And that's the important thing, is that cardiac rehabilitators are trained to bring people from effectively just coming out of hospital and being released back home into gentle exercise again, and giving really good advice how to do that. And it's always going to be tailored to the person, because we often in a cardiac rehab group have people that have had heart attacks, and then people who've also had triple bypasses in the same room. So everybody has to be kind of tailored. So it's important you do get a tailored approach to your recovery, and definitely don't do this on your own. You do seek out groups, because they will be available. I'm not knowing where you're messaging from, obviously, but in the UK, we have cardiac rehab groups everywhere, and they typically run through the hospital initially. So we have a 4-phase program. Phase 1 is the immediate aftermath of having your event, and you're in hospital and you're beginning to get some information about what to do. Phase 2 and 3 are clinical exercise, and then phase 4 is community-based exercise, which is typically run in either community centers or in specialist centers, gyms that have cardiac rehabilitators coming to do the work there with the patients.
Thank you.
Yeah. Okay, so let's talk about some absolute contraindications to training post-cardiac event. Okay, and actually some of this may even apply to some of us who have not had any cardiac event as well. So unstable angina, diabetes, or heart failure. So unstable means that it is changing. So angina that cannot be replicated doing the same things. It comes on suddenly after eating, for example, which is known as postprandial angina, or something that is just completely, or you go out in the cold and suddenly you're getting angina pain, and that's not happened before. So anything that would be considered unstable. Same with diabetes. You're not getting relief from your medication in the same way that you have, and you need your dose adjusted. And heart failure, that seems to be with the symptoms getting worse, greater swelling, anything like that. New or uncontrolled arrhythmias. Okay, now arrhythmias is a big thing. So there are lots of different kinds of arrhythmias. For me, I had something called an ectopic heartbeat, which is a form of an arrhythmia that's connected to athlete's heart. It was new. I got it checked out. I made sure it wasn't anything nasty. Okay, so anything new, get it checked out. Resting tachycardia. So tachycardia is a heart rate that's over 100 at rest. Please don't exercise if that's the case for you. Resting systolic blood pressure. So that's the number on the top when you're looking at a blood pressure monitor. And if that's over 180, or a resting diastolic at 100 or over. So if either one of those numbers is that or over, it doesn't have to be both. If either one is over, please don't exercise. Symptomatic hypotension. So a sudden loss in feeling okay after, say, getting up or getting off of a surface and suddenly feeling the blood pressure drop, which is what hypotension is. Symptomatic, so any feeling like it makes you feel unwell, definitely don't exercise. Febrile illness. And I would say about febrile illness, if you're feverish, obviously you're not going to exercise. But within the days following a febrile illness, give yourself a good 3 or 4 days following a febrile illness before you return to exercise. And then when you are returning to exercise, we're not going to go and jump in and do an aerobic threshold workout. We're going to go in and do something really gentle after a febrile illness, 4 days maybe afterwards. Okay. Any new chest pain, definitely don't exercise, please, because until we know what it is, it could be a pulled intercostal muscle, or it could be something else. Don't exercise with new chest pain.
Certainly, the rule of thumb for exercise is the amount of time you've taken off equals the amount of time it'll take you to get back the fitness you had before.
Precisely, and longer if necessary. It's better to be safe than sorry. Don't be in a rush to make it up.
Susan asks, if contraindicated, is just a gentle walk okay?
I've contraindicated. So we're talking about training. When I mentioned training, I wasn't very specific in what I meant by training. Contraindicated, it depends on what you're contraindicated. If you've got a resting systolic blood pressure at 180, you probably don't even really want to be walking. You want to just sort of take it easy. Okay, so you've got to kind of gauge that for yourself. But I'd say if you have febrile illness, you probably just want to stay put. You don't want to be walking outside. If you've got chest pain that's unexplained, probably don't want to be walking outside. It depends on what the contraindicated thing is, but I would say just take things easy. If you've got something going on, resting tachycardia, probably just don't want to be exercising. So I think people typically get quite impatient to get back or to do something, even though they're not 100% there. And I'd say particularly in the masters group of athletes, just treat your body a little bit more carefully. Just take a little bit more time to get over things before we jump back in. Okay, so number one rule. Out of all of this, forgetting the numbers, forgetting Karvonen for a moment, always listen to your body. So if something feels off, don't train, don't compete. It's not worth it. Seek the advice of a medical practitioner. You want to be doing this stuff for the rest of your life. And honestly, if it just doesn't feel good, then don't do it. So as a group of athletes, masters athletes, many of us have been doing this for many years. We're quite bodily aware. We're quite internally aware of how things feel. And I want everybody just to go inside when you are training, just to feel how things are feeling. And if it feels like you just feel a little tired today, or perhaps you have a wearable like an Aura or a Whoop, and you've got a little bit of a higher resting heart rate the next morning, you're not recovering quite as well, that would be a good time just to sort of take things easy. Okay, so those things are really important. Now, I've got a few notes here just to talk to you quickly, guys, about AFib, because it's not something that I mentioned. And I know that this is, particularly in our cohort of athletes, really important. So atrial fibrillation, if you imagine we've got the heart, we've got 4 chambers. So the top 2 chambers are called the atria and the bottom 2 chambers are called the ventricles. Now, fibrillation is when the parts of the heart aren't filling and emptying properly, but instead they do something called fibrillation where they quiver. Okay, so what happens in the instance of atrial fibrillation is that the blood isn't emptying properly into the ventricles and it hangs around because the atria are fibrillating. So the risk there is that the blood doesn't empty there and it stagnates, and that's where the risk of a blood clot or stroke appears. Okay, so in endurance athletes, and particularly in our group where potentially many of us have been exercising, doing endurance work for many, many years, there is this risk of atrial fibrillation in our cohort. So we have a 2 to 7 times higher risk of AFib due to structural heart changes from chronic long-term endurance exercise. And this is really important to note. So fibrosis within the heart walls is one thing, and then we get this left atrial enlargement sometimes in endurance athletes. And this is coming from Cecile Polika-Devath from the NIHR Academic Clinical Fellow Cardiology with the British Cardiovascular Society. That's her work. And the prevalence of AFib is roughly about 2.5%. So having athlete's heart can increase the risk of AFib because of the structural remodeling of the heart when the heart is, like the muscle of the rest of our body, does grow larger. So it is just something to bear in mind. And this is going to take me back to UT2s and why it's so important to work these lower rate works, training, really, really important that we do them. Because what we're doing with these UT2s is we're building the capillarization of the heart. We're building a strong heart from a very low under threshold kind of basis, which is making the heart much more able to do its job. Now, when we do very long pieces of quite high intense work, say we're doing UT1 for hours at a time, and that becomes what we want to do every time we go into the erg room, that's the stuff that kind of puts us a little bit more at risk later on. So I would say as an older athlete, and since I have, certainly from my own perspective, since I turned 40, I'm now nearing 50, I pay much more attention to doing my lower heart rate work well and not overcooking my UT2s. because I don't want to put my own self at risk later on. Now I still do my UT ones, but I just don't do them like I did in my 20s. I don't do them many times a week. I might do a UT one a week. Now we're going to get on to kind of more kind of individualized training programs, but this is just speaking for myself. I don't do UT ones in quite the manner I did in my 20s. So UT2s become the basis of my heart health.
One of the things that we found is for the UT2 work that we recommend, instead of giving a 45-minute session, we give 3 15 minutes, because then you can check your heart rate at the end of the 15, you have a minute rest or whatever to have a drink, and then you can reset yourself to what you need to do for the next 15 minutes, which might be a lower effort. So rather than try and carry on and hope that your heart rate drops, stop, reset, go again. The training effect is very similar, just having a very small break and breaking it into sections.
Yeah, and a very, very good idea. And then we get that rest afterwards. And certainly if you've come from any kind of cardiac event and you are doing any kind of exercise, it doesn't matter what it is, give yourself time to cool down at the end. If you've jumped off from doing an anaerobic threshold, I mean, typically our advice in cardiac rehabilitation is to take 10 minutes, 15 minutes at the end of a session and spend time just cooling down, just getting the heart back to homeostasis slowly. So we don't just suddenly stop and then jump off the erg and then get into the car and go. We spend some time kind of letting the blood circulate around. We also, as we get older, the veins in the legs are not quite as good at shunting the blood back up to the heart. We have collapsed little shunts in the lower legs. We get things like varicose veins, and we get blood pooling in the legs. So all the more reason, just spend 10 minutes at the end of your session. Doesn't matter if it's an easy session or hard session, just circling, just getting a little bit cooled down. That could be just walking around the room. It could be getting on the bike erg and just very gently circulating the legs around, just no work at all, but just letting the heart rate come down slowly. And that also helps us to reduce the risk of arrhythmias at the end of a session as well.
Lovely. Now, was that your last slide?
That is my last slide.
Right. Let's launch in, because, oh my goodness, we have questions. So first one from Joe. She says, we were going back to the discussion of beta blockers. What about people on propranolol for potential either exercise-induced migraine or prevention of bleeds on the brain?
Oh, gee, I'm not sure. I've heard of prevention of bleeds on the brain and exercise induced. Is this something that she suffers from because of her? Has she spoken to a GP about this one? Because I know that some beta blockers can cause problems for people. So I'm not entirely clear as to whether or not this is a side effect of her drug, or if this is separate too, or if this has been checked out. She may just want to keep a symptom diary. And I think symptom diaries are good anyway for everybody to keep. So what are we doing when these migraines are coming up? Is it a specific form of exercise that brings them on? Or are they just kind of appearing in your day? Could it be worth speaking to your GP about switching brands potentially? Okay, so people don't realize that they can ask to switch if they've got side effects that are becoming intolerable. That is a possibility. I always ask my patients how they're doing on their particular drug, because they can ask.
Good. William says, can you comment on enlarged ascending aorta from rowing?
Oh, have you had an MRI? I wonder how you ended up finding this out. Okay, so again, another thing for a sports cardiologist, a very, very good question for a sports cardiologist. Are you having any new things happening to you at all with an enlarged ascending aorta? Is there anything going on that you feel that might be significant? So if you have very specific things that you know about yourself, that may be worth seeking the advice of someone highly specialist in that area. So we're thinking kind of more on the side of sports cardiology to ask that question. And they do exist. They do exist. They are there. And actually, they quite like people to study. So contact one.
They like people to study. I like that. So a response here to Daniel's earlier question from David. He said, when I was 39, I had a cardiac arrest, received a quadruple bypass. And at the time I was playing soccer. It took me almost 18 months to recover to pre-event fitness, but I'm now 53 and have raced 2K racing with 18-year-olds, and I continue to row in the master's grade. So stick with it, Daniel. And
wow. Thank you for supplying us with that story, because that just goes to show you I'm quite impressed. I mean, that really is. I mean, the fact that you were able to overcome the fears around what had happened to you and you continue to train, I think that's testament to just how possible it is to come back after something like an MI or a triple bypass and continue to do very, very well indeed. In fact, you're reducing your risk as you've gone because you're doing what you're doing now. So well done you, really impressive.
Rachel has a question. Irrespective of how high our heart rate goes in training, should we set our training zones based on the Hunt formula for MHR rather than our measured heart rate? Now, Rachel, I know that she's an endurance athlete from way back in rowing and running and now in rowing. So,
yeah. So again, this is kind of the Hunt formula is geared towards older athletes. It's geared towards people generally. There is going to be a little bit of leeway. And I think you, as someone who is obviously a very experienced athlete, will know what is right for you. And likewise with myself, I tend to be a little bit more of a higher ticker. So I give a little bit, maybe give or take 10 beats for a lot of my zones. But as I say, as I've gotten older, I've definitely focused more on trying to do my lower heart rate work a little bit more measured and a bit more carefully. But try the Hunt formula, see how you get along. If you find that, say, up at the higher zones, it doesn't seem to apply to you, but it maybe can at the lower zones, then just factor it in for yourself. If you're not at great cardiac risk, i.e. you haven't had anything happen to you, you haven't had an MI, you don't have angina, you haven't had any history there, then you can probably just tailor it a little bit for yourself. So we are all individuals and our hearts do behave the same way. I was only erging with someone today who had a very different response to what we were doing. We were side by side on RP3s today. I say hello to Shem, who may be watching. And he had a very different heart rate response to myself. There is probably about 10 years of age difference between us. But nonetheless, for the amount of work, we have very different heart rate responses. So it's really important to know that your particular way that your heart works maybe maybe a little bit different to what you might be seeing for percentage zones for using the Hunt formula and Karvonen formula. So just kind of tailor it a little bit for yourself. Take your own risks into account, and then just factor that in. Okay.
Very helpful. Manpreet asks, is there any specific guidance to follow with training if you have SVT?
Yeah, and again, I think with this, you would probably just want to make sure that you've gone through a good cardiac rehabilitation program, okay, or you're in touch with somebody who's a cardiac rehabilitator. So yeah, and again, just you can do it as long as that you've been in touch with a doctor, they know exactly what your history is, you've been checked out. And again, as I mentioned at the beginning of the segment, the tests are really important. So just knowing that your ECG is okay, knowing what your cholesterol is, knowing that your blood pressure is okay, and then just taking that into account as you're training. So be in touch with a really good cardiac rehabilitation group locally, because that will help you as well. Just being in touch with someone who understands it.
Lovely. Satinder asks, what are the signals that indicate a potential for AFib?
Okay, well, this is not something I actually know about. Okay, so I don't know what the signals are that indicate a potential for AFib, but what I will say is the risks are lots of long, intensive work. Okay, so we're thinking about UT1, aerobic threshold or AT work, where we're doing this for a long time, over many, many years. So this is a many years thing. Okay, that is the potential for risk for AFib. But how our heart beats, I couldn't say really. I know in my own personal situation that my father has atrial fibrillation. He was an endurance athlete. I have a really high ticker. The chances are maybe I might get AFib too. I know that I have a really high ticker. That might be something, but it is the structural remodeling of the heart. It is the fibrosis. It is the going in and out of athletes' heart regularly that may pose the risk ultimately.
Nice. Stephen has a story. He says he's been rowing since his school days and he's now 62, and he had a heart attack 2 months ago, cleared by medication. Angiogram showed the arteries are good order, no blockages, and it did find a myocardial bridge, and the flow rate was checked and it was okay. I've not had any problems since, not on any medications now. Have changed my lifestyle, retired, eating a natural diet and walking, gentle exercise, feeling great. Have you any knowledge of this?
Well, I mean, it's interesting because you've had an MI. It was 2 months ago. Wow, cleared by medication, but you're not on any medication now. That's a little unusual. I'd say that's definitely not something I see a lot of. Typically with MI patients or MI outpatients, they're on cardiac drugs for quite a long time. Okay, so they're on something to stop this from happening again. So it depends on the nature of your MI, whether it's an anterior MI, a posterior MI, so what side of the heart this happened on. Typically, one is worse than the other. But if you've been cleared by medication and you're getting a regular checkup, that's important, because if you've had an MI, you want to get checked out regularly. It's at least once a year just to make sure things are okay. I'm not sure if this person is a rower, so if you're doing training as well, that's even more
Yes,
reason
he's
to.
been rowing since his school days. So he
Okay,
may
so
not
rowing
now
since
be
school days.
rowing, but
Yeah.
was.
Yeah, so yeah, go ahead.
Mark says, I've also been diagnosed with an enlarged aorta. I now repeat the MRI measurement yearly, and it's not gotten any larger for several years. So that, as you say, regular updates.
Yeah, so we do MRIs to check for what's known as the remodeling of the heart. So the heart remodels depending on what's going on. So actually, really interestingly, in swimmers compared to other athletes that are upright athletes, so rowers, runners, cyclists, swimmers' modeling of the heart is very, very different. It looks different. The physical structure of the heart looks different when you're in a horizontal plane, and the stressors on the body are different. So our heart remodels for all sorts of different reasons. MRIs are great because they show us what the remodeling of the heart is doing.
Isn't that interesting? Marla says, at our morning row this morning in Canada, most of the masters were in the 70-80 age category. Any specific cautions for athletes in this age group? Well done, you, Marla.
Yeah, I'd say absolutely brilliant. My gosh. Well, it's hard to say because, you can get 49-year-old who's had a heart attack and an 80-year-old who's never had any cardiac history at all. So I don't think there are any specific cautions per se. But obviously, as we age, the risk of cardiac things and cardiac events and cardiac conditions go up. So I'd say it's more important just to make sure you're getting checked out once a year. Okay. So checking in with your doctor, getting cardiac specific checks done. And we talked about the ECG, okay, as being really important. Those sorts of things are really important. Just keeping on top of your health, understanding what your cholesterol and your blood pressure is doing, perhaps even keeping a blood pressure monitor at home.
Nice. JA says, if you've got a low resting heart rate of an average 49 to 50, but a high for your age maximum when you're erging hard, the heart rate formula makes a potential easy sessions of UT2 feel too hard. What's going wrong?
Oh, well, that sounds a little bit like me. So I'm a very low resting heart rate, and I shoot away up sometimes when I'm erging hard as well. So again, go back on feel, go on RPE. How's it feeling to you? So you don't have to look at the numbers all the time. They're there for a guideline, and that's really important to know that they're as a guideline. Obviously, we don't want to go over them greatly when we're doing things that are supposed to feel easy. But if UT2s are feeling too hard, take the work off your legs, flip the screen away, and go inside your body. How's it feeling? How's it feeling?
Drop to
And actually, just on that note, yeah, up to UT3. So on that note, when I do my UT2s, I breathe through my nose only, and that's how I can gauge how hard I'm working. So I'm quite well conditioned when it comes to breathing in and out through my nose. I have a very high carbon dioxide tolerance, so I can breathe in and out through my nose very well. That could be something you could try, okay, or even just to perhaps put a little bit of mouth tape on to keep yourself from opening your mouth, and see if you can do a really light erg just through your nose to gauge a really low output.
Nice. Joanne asks, what is heart rate variability? I have long-term fitness and good HR recovery. According to Google, a higher HRV is better. Mine seems to be low.
Okay, so HRV is really how we flick between parasympathetic, which is our rest and digest. So that's when we're completely relaxed, and sympathetic, which is when we're called to action, when adrenaline and cortisol are working together, and how we flick between the two. How easily do we transport ourselves from high stress to rest? And that is an indicator of stress. So if we have a lower HRV, it means that we're not recovering very well from stress, and that potentially we're becoming even potentially a little bit cortisol resistant, much like diabetics are resistant to insulin. We can become a little resistant to the amount of cortisol that our body's putting out when we're stressed out, and that reduces our HRV. It makes our HRV very low. So there are methods, and I won't go into it now, to improve your HRV. Are you, Joanna, maybe you've got a wearable and then you're getting that information, an Oura Ring or a Whoop Band or something, or maybe a really good quality watch is giving your HRV. It is a number. So these things can be a little bit inaccurate sometimes, but it is an indicator of how you're managing your stress. So look at ways that you can manage your stress, and that will help with your HRV.
Nice. And our last question from George. My background is a 72-year-old lifelong rower and sculler with a successful ablation for AFib last year. Any comments on a bicuspal aortic valve? I recently noticed on a transthoracic MRI. I was on the national team in my 20s, and I didn't notice I had a performance deficit.
Oh, interesting. So a transthoracic, yeah. Well, keep an eye. So when did you get this MRI done? Does it says recently? Yeah.
Yes.
And how old are you? Sorry, how old is this person again?
72.
72.
And he had an ablation,
and a successful ablation for AFib last year. Okay. All right. So yeah. Keep an eye on how you're feeling when you're training. If things change in your recovery, if things change as you're training and you're not feeling good, or if this is the stuff to pay attention to, particularly with a cardiac history like this. Okay, so I don't have a specific comment on bicuspid or aortic valves at all, but I'm saying I'm going to lump this in with anything that you're recovering from a cardiac perspective, that you've gone through an event, is keep an eye on how you feel. Make sure you've been checked out, make sure you're cleared for exercise, and if things change, get you to a doctor, get right back and get it checked out. Don't ignore it.
Very, very good advice. Becky, I'm going to draw it to a close. You're being so generous, not only with your expertise, but your insights and answering so many questions. And for everyone who's watching, I will share the slides, and you please take the advice. And if there's any opportunity to speak to your colleagues, teammates, share the knowledge.
Thank you, Rebecca.
So here we go. Lots and lots of thank yous coming through from some of our
brilliant.
So for everyone else, please stay watching. It's been a delight having a guest here who's so knowledgeable, both as a rower and also as a medical specialist. And till next time, bye-bye.
We are part of the Rowing Chat Podcast Network. Please tell your fellow rowers about the show. If you've learned just one helpful thing from today's episode, please consider supporting the show for as little as $1 per month by visiting fastermastersrowing.com/podcast.